These are my financial disclosures. None have anything to do with this talk. These are the objectives. So understand how nociplastic conditions, including CRPS, the most common form of CRPS, affect procedural outcomes. Recognize the factors associated with outcome for ketamine infusions in CRPS, and be familiar with the common mechanism as to why sympathetic blocks and ketamine infusions may improve pain in CRPS, and to why response to sympathetic blocks can predict response to ketamine. So, in 2016, the ISP formalized the term nociplastic pain. It was proposed as a mechanistic descriptor for chronic pain states that were not characterized by obvious activation of nociceptors or damage to the somatosensory system, but in whom clinical and psychophysical findings suggest altered nociception. So it's defined as pain that arises from altered nociception despite no clear evidence of actual or threatened tissue or nerve injury. So nociplastic pain is a huge thing. It should be a really huge thing in psychiatry. I also I'm a professor of psychiatry at Johns Hopkins and the military medical school as well. It can be diffuse, i.e. fibromyalgia, chronic widespread pain, but the more common is regional, and it can occur in up to 30% of people based on validated instruments. There's a strong female prevalence, and there's an absence of biomarkers, which makes it challenging to diagnose and more challenging to treat. So we think in pain that mechanism-based treatment is better than symptom or condition-based. And with syndromes in general, they're not diseases. So fibromyalgia may be 15 or 20 diseases. There are many different mechanisms. So these tend to be associated with poorer outcomes. There are many different types of nociplastic conditions. Complex regional pain syndrome is one of them. We did a review on these nociplastic conditions in Lancet in 2021, and we note that it's an outlier because there are more physical signs. In fact, physical signs are required. People with nociplastic pain don't do well with procedures. They experience aberrant responses to lumbar and cervical medial branch blocks, and the same group, Chad Brummett's group, found that they don't get as much pain relief after spinal radiofrequency ablation. We found that fibromyalgia was not associated with back pain procedural outcomes, but that if people who had other nociplastic conditions like pelvic pain, bladder pain syndrome, they had terrible outcomes. People who have spine surgery and joint replacement, including knee replacement and hip replacement, they do worse. And they're more likely to experience persistent post-surgical pain. And the bottom study that I showed, Roche, and this is not unique to total knee arthroplasty, but I wrote that over here. If you have nociplastic pain, you're more likely to have a complication. You're more likely to report complication. So why do they fail treatment? Well, people get operated on when this, what they're operating on is not really causing pain. And so this is a big problem, right? Lots of people have pathology and it doesn't cause their pain. So there's a poor correlation between pain and pathology in general. It's extremely poor for some conditions like hip arthritis and knee arthritis. People with nociplastic pain across the board have sleep dysfunction. There's an extremely high co-prevalence rate of psychopathology. I didn't put these slides in here, but almost across the board, it's more than 50%. They have aberrant responses to diagnostic injections, as I showed. They have high incidence of non-organic, so i.e. like Waddell signs. And so we've done a lot of research on that. And they have poor response to opioids. They have dysregulation of endogenous opioid systems. And, for some of the conditions, they probably have, elevated endogenous opioid levels in the CSF. So what how can we treat CRPS? Well, in a Cochrane database review, they found low evidence for bisphosphonates, calcitonin, and a daily course of IV ketamine compared to placebo. The problem is, with ketamine studies, almost uniformly, there's only 2 that looked at, but blinding was terrible. So the large majority of people were able to guess what treatment they got. Graded motor imagery was more effective than usual care. Mirror therapy, also effective for particular types of CRPS. But there's low quality evidence that sympathetic blocks, which we do all the time for CRPS, are not effective after 4 weeks. There's other reasons that we would do sympathetic blocks, to facilitate physical therapy, to identify sympathetically maintained pain, to guide treatment. In a study that was published almost 20 years ago, we found that response to sympathetic blocks predicted response to spinal cord stimulation in people with CRPS. So, the objectives of this study were to determine whether demographic and clinical factors and technical and psychophysical characteristics of sympathetic blocks were associated with response to ketamine infusion. And it's really important because at least here in the United States, there's, ketamine infusions are very expensive. There's no CPT billing code from Medicare, so it's often thousands of dollars out of pocket, and they do contain risks. There's a lot of resource, and so screening tests are very important for these types of procedure. So this was a study done at 4 sites: one Seoul National University, Cleveland Clinic, Walter Reed, and Johns Hopkins. We used ICD billing codes to identify patients who underwent sympathetic blocks for CRPS type 1 or 2. This is the same across the board. Sympathetically maintained pain was designated as greater than 50% pain relief, and response to ketamine was designated as greater than 30% pain relief lasting for 4 weeks. So that was based on our ketamine guidelines. I was the chair of those ketamine guidelines for chronic pain. So we recorded temperatures on the distal palmar plantar sites. In one of the institutions in Korea, they only identified patients as having 50% or greater pain relief and less, so we didn't have the actual scores. We use chi-square, normal things to assess differences in categorical and student t-tests for continuous data. We examine correlations with Pearson's correlation, and we perform multivariable analysis, based on our assumptions and p-values in univariable analysis less than 0.2. So what do we find? Well, 71 patients were included at all 4 sites. These were typical CRPS patients. 85% had CRPS type 1. The difference between CRPS type 1 and 2 is that clinically they're indistinguishable, but there's no identifiable nerve injury with CRPS type 1. 60% were women. The mean duration was 4 years. It takes a long time for these people to be diagnosed, and the mean age was 40. The temperature rise was 4.6 degrees Celsius, and the average decrease after sympathetic blocks was 55%. So 58% of people were diagnosed with sympathetically maintained pain. In other words, they had at least 50% pain relief. 61% had a history of psychiatric condition. Most common was depression. 17% had a body mass index over 30. And 46.5% of people had a positive ketamine outcome. And the average score decreased from 7.2 to 3.6. So in univariable analysis, we found that temperature increase was associated with a positive outcome, that having sympathetically maintained pain, in other words, having at least 50% pain relief was strongly associated with a positive outcome, and obesity was associated with a positive outcome. So 3/4 of people who were obese had a positive outcome versus less than half who were not obese. We did not find that psychiatric conditions and other psychiatric and other variables were associated with outcome. So this is multivariable logistic regression. So you can see that that increase in temperature, because it was collinear with pain relief, falls shy, and the 2 things that were associated with ketamine response were being obese and having sympathetically maintained pain. In other words, pain relief from the blocks. So, how do you explain this? Like I said, as someone who's, our group developed the IV ketamine test to see if there was a correlation with dextromethorphan, and I had chaired the ketamine guidelines, and I've done a lot of lectures on this. There's more than 6 studies that have evaluated quantitative sensory testing, and 2 or 3 studies that have looked at conditioned pain modulation and the effect that ketamine has on these. And across the board, after 48 hours, so ketamine is out of your system, it's more than 5 half-lives, no studies really find that there are any differences in any type of pain threshold or pain tolerance. But we know that some people experience prolonged relief. We know that ketamine is effective for depression. We're about to get over $2 million in Restaural funds to look at stellate ganglion blocks and ketamine for PTSD and traumatic brain injury. It works for anxiety. And the mechanism for these types of conditions is a little bit different. Probably involves increased AMPA glutamatergic activity and brain-derived neurotrophic factors. So if some people feel better with ketamine, but they have no increase in their pain threshold or pain tolerance, why are they feeling better? Well, it's very, very likely because it affects the affective motivational component of pain. So many years ago, Ron Melzack, one of the inventors of the gate-controlled theory of pain, postulated there were 3 different components of pain. There was sensory discriminative component, which deals with pain intensity, location, quality of pain. Then there's the affective motivational component, deals with like fear and anxiety, and a cognitive evaluative component that considers things like past experience and what's the prognosis. So when I was looking at this data, there was another study that found, it was not published in peer-reviewed literature. It was from George Washington University, our neighbor in Washington, D.C., and they found exactly the same thing, that if you were obese, you are more likely to respond to ketamine. So I did some more looking into this, and there's at least 2 studies that have separated, pain in patients into like sensory discriminative and affective components. You can do this with a lot of different instruments. One is the McGill Pain Questionnaire. And all of the studies, or both of the studies that I found that obese patients have a higher affective component of pain than non-obese patients. What's the evidence in clinical trials? Well, there's 2 very, very small, randomized trials looking at lumbar and thoracic sympathetic box, and they both found that there were reductions in depression. The mechanism for a reduction in depression, you can see by the images here, my daughter Seffrah drew them, is that it reduces elevated cytokine levels. So we did not find that there was an association with psych history, but we actually didn't measure depression or anxiety. We didn't use HADS, or we didn't use like PCL5 to measure like PTSD. So most of our patients were stable. And a shared mechanism is also a very strong placebo effect for both. So the placebo effect is extremely strong for pain. The only thing that compares to the effect for pain are psychiatric conditions, but the placebo effect is also a lot stronger for procedures than it is for pills, and especially for procedures like sympathetic blocks and ketamine infusion, where the physical effects are very obvious. So in summary, ketamine may be effective for nociplastic pain conditions, including CRPS. The mechanism for long-term effect doesn't seem to be secondary to increase in pain thresholds or tolerance, but may be due to a reduction in the affective motivational component of pain, which again is mediated through AMPA receptors and BDNF. Sympathetic blocks rarely provide long-term pain relief. They can alleviate depression via reduction in cytokine levels, and sympathetic blocks may predict ketamine infusion results via alleviation of the affective component of pain or via a robust placebo response. Thank you. I can stop screen sharing. I guess I can take questions.
Yeah, thank you very much indeed. That's, it's really excellent and fascinating topic. Can I just ask a couple of sort of clarificatory questions? With the ketamine, was it dosed on a per kilogram basis?
So it was not. So, we actually stopped doing ketamine infusions at Johns Hopkins outside of clinical trials. So we're about to start, well, probably not about to start, but we have about $2 million for a study looking at stellate ganglion blocks and ketamine for TBI PTSD that's funded through restoral funds through the DOD. And then we're looking at this concept called, the dermatologists call it neuropathic itch. We call it, it really should be NOCIPLASTIC itch. We will have a brief report we just submitted a small revision, just a brief report to JAMA Dermatology. So it looks like they're going to accept it about ketamine for like diffuse itch called neuropathic itch. So when we do these, we do these based on like a personalized medicine model. So, we do infusions, we see how, people are tolerating the infusions. But in general, we would try to, for chronic pain, we would try to exceed 400 milligrams. So our group did a meta-analysis. It was the cover of Anesthesia or Analgesia, I think, in July 2019, that looked at, really factors associated with a positive outcome. And, using a rock curve, we found that, 400 milligrams seemed to best discriminate, to best predict, response. So 400 milligrams or greater doses.
Over what sort of period?
So the 7 purportedly placebo-controlled trials used every kind of combination, so it was very difficult. So one of them, did a 100-hour continuous inpatient infusion. Another one did 4-hour infusions over 2 weeks. Another group did, infusions just every day for 1 week. A bunch of groups just gave for a few hours or 1 day. So very difficult to kind of compare, to compare that. And probably, my opinion is that, it's not only dose, but it might have to also do with, peak blood levels, and not just peak blood levels, but rate of rise to peak blood levels. So there may be many different factors, but the literature is pretty clear, and the depression literature, which I'm not as familiar with, is very clear as well, that, there's a dose response. There's a dose response for depression, there's a dose response for pain.
Can I just ask, I mean, that just something you said as you flash by, the rate of rise you think might be important. One of the purposes of this meeting is to sort of just allow people to speculate and and I wondered if you could speculate on why you think the rate of rise might be important. So, for example, in psychiatric conditions, there are some people who would say that intramuscular ketamine might be more useful in some circumstances for people with depression than intravenous, because it has a faster rate of rise. And I'm curious as to what made you say that.
Well, I think you must have transpose those, right? IV definitely has a faster rate of rise than IM. But we have a big psychedelic center at Johns Hopkins, through the Department of Psychiatry. Like I said, I have a joint appointment in psychiatry. And they're looking at all these different psychedelic medications. So for ketamine, for example, the psychiatric literature, I believe there's even a meta-analysis on this, shows that IV medications work better than IN. So Obviously, the rate of rise is very fast for IN. There's 100% bioavailability.
Sorry,
For IV compared to IN, there's 100% bioavailability. So the relative doses are higher. But, in people who get very, very low infusions, like over an extended period of time, like if you were to get 800 milligrams over 10 days or 11 days, like a lot of our sickle cell patients, they don't experience a lot of the psychedelic effects. So, and people think that I think there's more data on this for psychiatric conditions than there are for pain, but they have them for both. So psychedelic effects seem to be also kind of correlated with pain relief. In fact, I think there's something in the psych literature, and it was something like 27% of studies show that there's a correlation between having psychomimetic effects and response. So, like I say, faster infusions, faster rate of rise, higher peak blood levels would result in kind of more of these psychomimetic or psychedelic effects. So this is just, I'm just guessing here. This is a hypothesis.
Yeah. Okay. It was actually intramuscular that I meant IM rather than IN. Where obviously you have a slightly higher peak rate of rise for the same amount of drug. So if, for example,
right, you mean IM to IN, because IV it's dramatic.
No,
I mean the rate of rise with IV, it's enormous. I just sent like PK tables, right? It's 100%. It just goes right in. There's nothing that's IV in terms of rate of rise and bioavailability.
All right.
The rate of rise for IM is kind of similar to that. It's slower. It lasts longer.
Okay, so have we got other questions from others? I can't say now. My chat seems to have gone. I can't see it.
So Abraham writes, does chronicity of CRPS have any relation to the effect of ketamine? And people with CRPS, it takes a long time to diagnose it. Treatments are generally poor, but almost across the board for chronic pain, greater disease burden, including longer duration of pain, is associated with poor outcomes. It hasn't specifically been looked at with ketamine and CRPS, but almost across the board for back pain, for neck pain. And then Dr. Hamidi writes, sorry, missed the beginning, 400 milligrams. No, this was a meta-analysis. Like I said, it was in July. It was the cover of the July 2019 issue of Anesthesia Analgesia. And, looking at 7 randomized controlled trials, they found, using a receiver's operating characteristic curve, we found that 400 milligrams best discriminated between responders and non-responders. And what came up was that, 400 milligrams, these studies didn't standardize administration. So some of them were over days, hours. One was 2 weeks. There's another question by Tiago Gill. There's small research on stellate ganglion blocks for CRPS and reduction of PTSD. So I'm really familiar about this. Like I say, we're about to get a grant, looking at this. So, and so we actually are, I'm not the first author. I think I'm the second author, but the group at the military medical school, the Uniformed Services, published something like in Medical Hypothesis on a theory for, why in my opinion, stellate ganglion blocks for PTSD, they're not proven. There's out of the 2 randomized controlled trials, one was positive, one was negative. Other than that, you have anecdotal data. So when you look at stellate ganglion blocks for CRPS, the Cochrane review and almost all, even all studies published since then are really clear. You don't get long-term relief. And that, for CRPS, there's more biological plausibility because these people have CRPS in their arm and you're blocking the stellate ganglion. For PTSD, you have to ask, well, why would blocking the stellate ganglion on the right side provide long-term relief for PTSD? And a lot of the people who do this, the people in the military say, well, a lot of the emotional centers are on the right side. One study is positive, one study is negative. The problem with, stellate ganglion blocks is, they're not blinded, because almost everybody who has an effective stellate ganglion block develops a Horner syndrome. And I could tell you from the Department of Defense, like everybody talks about it, they know about this. They talk about, their eye looks funny, they become hoarse, it looks red, they develop, anophthalmos. So, like I said, again, the placebo effect is indisputably higher than the intrinsic effect for almost every kind of pain treatment. And I would imagine it's the same for psychiatric treatments. The placebo effect is so high. And this is an indisputable, statement. You look in randomized trials that lead to, European Medicines Agency or the US FDA or Canadian FDA approval. And you see that the between group differences for pain, they're 20% is very high, but the within group difference for the control is almost always 20%. And that's why you have such mixed, fibers. Like I said, I think that that cytokines, definitely play a role in both, right? They clearly play a role in depression, and then in CRPS. CRPS is very high, is very difficult with depression, right? Because it's not a disease, it's a syndrome. So there's no real specific pathophysiological mechanisms or biomarkers. So like I say, it might be 15 different diseases. Are there similarities between CRPS and gadolinium deposit disease, and does ketamine help to treat? I was a co-author on the gadolinium guidelines, for like epidural steroid injections, and I don't know the answer. I mean, gadolinium deposits can cause just all sorts of problems. Our guidelines say don't use gadolinium for most epidural injections. And ketamine, in that meta-analysis I was saying, we separated, pain conditions into neuropathic, nociceptive, nociplastic, and mixed, and it didn't seem to make a difference. So ketamine can help pain conditions across the board. Mohan Nair, does C fiber pathology connect in any way to the central effects of ketamine in CRPS? So I don't know the answer to this either, but people with nociplastic conditions, so they actually have small fiber neuropathies. It's about 40-something% in patients with fibromyalgia, and they have decreased density in the epidermis, in CRPS. So like I say, ketamine works across the board for neuropathic pain. There are no medications approved anywhere in the world for small fiber neuropathy. So you just have to extrapolate the data for neuropathic pain in general to small fiber neuropathy. This is interesting. Jonathan Sporn, is this the same thinking affective component for the efficacy in cancer, neuropathic, and other pain? We're developing an oral ketamine analog that's less dissociative and longer acting. Would that be worth discussing for CRPS? What are the challenges studying CRPS? So, yeah, cancer is a really tough condition, right? Because there's very, very, very strong affective components, right? Fear, anxiety, And there's also a strong cognitive evaluative component. And, traditional analgesics, are not very good at treating these things. Ketamine might be better, right? It works more on the affective component of pain, and it may, I don't know the literature on this, but maybe it works for depression because it changes someone's perspective. So it may work on all three components. CRPS is a really tough condition to study because, again, it's a syndrome, it's not a disease. So there's always going to be some controversies around diagnosis. There are different criteria for clinical and research in the Budapest criteria. And syndromes as a whole have much poorer treatment outcomes than diseases because you can't do mechanism. So you look across the board: irritable bowel syndrome, migraine headaches, bladder pain syndrome, interstitial cystitis, atypical facial pain. They don't do well. So it would be great. There's nothing that's approved for CRPS anywhere in the world if you had this to work, but it would be hard to show efficacy. Next thing, by Dr. Hamidi again, can response rate be correlated with peak effect? I believe IM would have a higher peak effect. So this is what I'm confused at. If you look at peak blood levels for the same dose, I'm an anesthesiologist. It's higher for IV. If you give somebody 10 milligrams of morphine or 10 milligrams of ketamine, the rate of rise to the is faster for IV.
So I think the confusion arises here from the way whether you're giving a bolus by both routes. So obviously IM comes as a sort of all at once, whereas typically what ketamine clinicians are doing is giving the same dose over 40 minutes. So that's where the confusion arises.
Thank you for clearing that up. That makes sense. I'm like, oh boy, I thought this was like intuitive. No. It could. Thank you very much for clearing that up.
We work in a different way. Yeah.
Yeah. So, could response rate be correlated with yeah, like I said, there absolutely seems to be a dose response for depression, for pain. I'd imagine for other conditions. So maybe IM would work better than kind of a slow infusion.
It's certainly the case that talking about the obesity effect, that obese patients, there's a link with a higher response in depression as well. So obese patients tend to respond better to ketamine than people who are not. And the conventional explanation for that is simply that the dosing has been on a per kilogram basis, and obviously that because it's not adjusted for weight very often, that may be an issue. But from what you were saying, you don't think that that's really the issue with CPRS.
Oh, that's really interesting. I wasn't aware of that literature, but we usually a lot of people give it like for lean, based on their lean body weight, or right. It's a very complicated formula, to kind of adjust it. There's another one. Do we need a trial with IV lidocaine versus stellate ganglion block to separate the placebo effect or the role? So the two studies that have looked at that have evaluated blinding, one did not give anything, and 28 out of 30 people correctly guessed their group. The other one gave midazolam, and people could still guess their group because the effects are different. So I would imagine that lidocaine might be similar to midazolam, but I'm not sure if people in this group know that IV lidocaine absolutely relieves pain. It works on sodium channel blockers, and there's a whole bunch of companies now like Merck, that are looking at like specific sodium channels that are involved in pain, like NaV 1.7, NaV 1.8. So lidocaine, there's tons of research in this. So it might, like I say, it might not be a placebo giving someone IV lidocaine. Yeah?
I'm saying it's just because the trials that I saw with CP, with post-traumatic stress disease, they don't use lidocaine IV versus stellate ganglion block to see if it's just the lidocaine running in the body that do something in the brain that we actually don't know, or is the stellate ganglion block itself that helps the PTSD. That's my confusion.
Oh, I see. Yeah, I mean, it's also challenging, and I'll tell you this, like I say, as someone who, so like IV lidocaine, right? So you're talking about for PTSD, but the other thing that lidocaine does, so you have to be very careful. Like if the vertebral artery is extremely close to where the stellate ganglion is, it's extremely close. So at Johns Hopkins, every person gets an IV no matter what. It really should be every place. If you inject 1 cc into the vertebral artery, they're going to seize. And lidocaine, lowers seizure threshold. Just something to consider. But now I definitely see your point.
I'm an anesthesiologist as well, and I do ketamine for mood disorders, and sometimes I use lidocaine IV for restlessness, for symptoms of agitation and something like, it's not mania, but just agitation and restlessness, and people usually respond very well to IV lidocaine, and that's what I'm thinking about.
Yeah, I mean that's tricky because you know that lidocaine, when you get toxic from local anesthetics, you actually get CNS excitation. That's why people seize, and then you get cardiac effects. So you probably have to
but it
be
blocks
very careful, cautious with the dose.
I am just 2 milligrams per kilo, nothing more than this, and in 40 minutes, and it works in the same sodium channels that oral meds usually do, as anticonvulsant medications used to treat mania and restlessness. They go to the same
No, thanks. So there's at least 2 review articles that write that there's an association between the duration of ketamine infusion and the response. But we feel that the duration of infusion is just a surrogate for dose. The dose is more important. And yes, you can become tolerant to ketamine, but it's very different than opioids, right? There's lots of different ways that people can become tolerant. You can have tolerance to like G protein receptor coupling. You can have, like internalization of like, receptors like down regulation. You can have desensitization of receptors. You can have behavioral tolerance. You can have metabolic tolerance. So people become tolerant to ketamine, but it's much slower and much different than with opioids. So for CRPS, I wish there was some kind of standardization for for treatment. The last thing, I think 4-hour IV infusion sessions are extremely common. That's what's done at Walter Reed. That's what's done at most of the DoD facilities that I'm familiar with. That's what we used to do at Hopkins. That's what they do at George Washington. When we published the ketamine guidelines, I got protocols, like about 20 different protocols, and that seems to be very common. That's also what's done in all these ketamine clinics that pop up, but sometimes they have them come back for more. So I think that's very reasonable, a 4-hour infusion session, titrating the dose to effect.
You get a sense of the durability of the ketamine effect for CRPS, sorry.
So in our guidelines, we had, this is based on nothing. It's based on the American Society of Anesthesiologists, saying, but Medicare determines the duration of effect that's clinically meaningful. So we just, had discussions with the FDA about like a new steroid that we're trying to get approved. You know, and did all these clinical studies and animal studies, and the FDA says 4 weeks is not long enough. For radio frequency, based on like the FACET guidelines, again, I was chair of the lumbar and the cervical FACET guidelines. We say 3 months. Medicare says, and you know, the guidelines say 3 months. Medicare says no more than 2 per year. So the ASA said, you know, if you're doing just a 1-day infusion, you know, less than 3 weeks is not clinically meaningful. You can't have somebody come back 52 times because they get 52, you know, they get 1 week relief. And they said, you know, 6 weeks was reasonable for like a multi-day infusion. You'd want to see 6 weeks worth of relief.
Of course, that's exactly what happens with Spravato, with intranasal ketamine. People do come back every week or every 2 weeks. And that's precisely the problem. You know, the question is, you know, they get a very small dose and it lasts perhaps, you know, 1 week or 2 weeks. The average duration of a single infusion of 0.5 milligrams per kilogram over 40 minutes is about 5 or 6 days in meta-analysis. Now, obviously, people will say that a lot depends on the affective state of the patient as they come into that, and that's I just wonder if you think that might be a similar thing in the CRPS.
I just say the last part again about the affective. I kind of think I might have missed.
Yeah. So the when people are given ketamine infusions, there are different models for how it's given. There are some people that do a lot of psychotherapy, for example, beforehand, and are convinced that makes a big difference to how long, what the duration of benefit might be. And there are others that would say, well, actually, duration of benefit depends on the psychotherapy and consolidation that goes on after the ketamine has been administered. You know, obviously with CRPS, as one's treating the effective component, so
that's interesting. So you think that psychotherapy as well might?
Well, I mean, I'm not arguing for that. I'm just really interested that particularly that you know, you're using very high doses. Typical patient getting ketamine 40 minutes, you know, might get 35 milligrams over 40 minutes. Okay, you're giving 10 times that much, and you know, they're saying, you know, it's not worth it unless it lasts 3 or 4 weeks. People people having very small doses of ketamine are taking it very regularly to get a continuing benefit from it. You know, and there's 1 or 2 studies of very long duration ketamine that suggest there might be a longer duration of benefit. So that's what I'm saying. You know? But obviously, giving somebody a 1-day ketamine infusion is not something that you can do outside a hospital.
Yeah, like I'd say it's a lot of resources, and I know that John's the average. I know this from just being chief of the pain center, so I see all the books. But you know, even though there's no professional billing code, so we do it like gratis, or we used to do it gratis, but the hospital bills $1,600. That's what Medicare pays, kind of median. So it's a lot of money. It's a lot of resources. And like I said, I don't know what the thinking, you know, for the American Society of Anesthesiologists to come up with their numbers, but a lot of it was in negotiation. And the 400 milligram, the last, you know, lidocaine is not really considered an NMDA receptor antagonist. Other NMDA receptor antagonists, you all probably know, right? Memantine, amantadine, dextromethorphan, dextrorphan. There's MK801, but that's not really available in you know, in humans. There's one systematic review that included carbamazepine. And again, you know, the 400 milligrams in the meta-analysis was just there was some studies that just did a one-time infusion, like over one morning, and there was one that did 4.2 days, and there was another one that did consecutive weekdays over 2 weeks. So there's no specific way. There was no one way that people got 400 milligrams.
I have a couple of questions, if you don't mind. Just like thinking back of the effect, right? I think and what you report in the paper, it seems that you didn't observe any effect on, depression or like mental health condition, but it made me wonder a bit, right? How was this measure? Was just like a yes or no, or did you use any specific scale to measure it? And also, what time point did you measure it? Because it was immediately after the end of your infusion, because sometimes we tend to see a peak of ketamine antidepressant effect at 24 hours.
So we, like I said, that was a big problem, in our study. We didn't actually measure depression and anxiety. We were just, the only thing that we did was we looked at were people with a history of depression all had relatively controlled depression if they responded better and they didn't. But that's something to, like in our DOD, we're gonna look at not only like pain scores, right? Because these people with PTSD, they have traumatic brain injury. So we're looking at pain scores, but also separating that into the affective and affective, motivational, and sensory discriminative components.
Right. And I also guess you didn't have, for what you were saying before, you didn't observe any dissociation during the course of your infusion, or did they experience any?
Yeah, I mean, this is just like I said, I did only a small number of the infusions, right? Because we have a dozen doctors at Johns Hopkins, there were doctors at Cleveland Clinic and Seoul National University. But yeah, I mean, most people get psychomimetic effects because we now do more of like a personalized model where if someone is like reading a book and talking on the telephone, we increase the dose.
Okay.
We try to give them as much as tolerated.
Right.